Thank you. Okay, so Professor York is going to help flip through the slides, and we will go back and forth in our dialogue as well to make sure that we do cover all of the topics. If you were not at part one, I just do want to hit a couple of points here of what to expect on your CMS. This is a 100-point item assessment, and it's going to look at your comprehension and mastery of adult surgical nursing. And what I want to stress is you will find questions as basic as fundamentals. You will find questions on pharmacology, nutrition, and disease processes on this assessment. You will have 1 minute per question, so plan to spend approximately 100 minutes for this test. And then what happened last session is that your score that you earn will actually be based off of that percent that you receive. And that is when National decided to go ahead and look at doing reviews to help you. This review is looking at the missed concepts on the exam and the low performing items. This is not an all-inclusive review, but it is only highlighting content where students have struggled on past CMSs across all campuses. Okay. The next slide is going to look at our breakdown. So we don't have as many topics on this presentation as we did on the first presentation, but I feel like these topics are just a little bit beefier or have more substance to these. Okay. And we're going to start off with our first topic, cardiac. When we look at patients that have angina and or MI, one of the interventions that we're going to do is we're going to give them nitroglycerin. You know that they're having an ischemia to part of their myocardial muscle, and that is going to create pain in this population. And the best way to deal with this pain is to give them nitroglycerin, which is going to vasodilate out those coronary arteries to allow more blood to get to that area of ischemia, which is going to have oxygen and nutrients in it that heart needs. When we look at treating a patient that is coming in with an MI, one way to remember all of the medications we need to give to this patient is using the acronym MONA. MONA does not prioritize interventions, but is only a way for us to make sure we're hitting all of the appropriate medication interventions, such as M stands for morphine. Morphine is a great drug for this population. It helps relax the patient. It's going to decrease their pain. It will actually vasodilate, so it will take some of that workload off of the myocardial muscle. The O stands for oxygen. N stands for the nitroglycerin. A stands for aspirin. When we do aspirin with the MONA acronym, our recommendation for the patient is to actually chew it, so it gets into their bloodstream much quicker than if they were to swallow it. And then if they're actually having an MI, the recommendation is to also give this population a beta blocker. That beta blocker is going to help with some of the symptoms, some of that pathophysiology that we're seeing with a STEMI patient. When we have cardiac cells dying, it's going to release their cellular content. There's going to be epinephrine in these cells. Also, when the patient starts to have their anxiety and get anxious, they're going to increase their levels of catecholamines. And this epinephrine is going to increase their heart rate. It's going to increase their blood pressure and make that heart muscle work harder during this time. On their skin, we're going to see that they are going to start to vasoconstrict and feel cool. When we give the patient the beta blocker, it's going to block the effects of epinephrine. So it's going to lower their heart rate, lower their blood pressure, and take that workload off of the myocardium. When patients are discharged, oftentimes they're going to be discharged with a prescription for nitroglycerin. Very important that the patient understands this medication and how important it is for them to either sit down or be in a laying position when they take this medication, because it can drop their blood pressure significantly. How many can they take before they call 911? So we remember that they can have a total of 3 nitroglycerin, but if they're having to take that second nitroglycerin, we want them to be calling EMS, and they should be seen, evaluated in the emergency department to make sure this patient is not actually having an infarction. With nitroglycerin as part of that home teaching, this comes in a dark bottle for a reason. It's very light sensitive, and it's also sensitive to air. So once this has been opened, it's only good for 3 months, and they need to refill this prescription. If their nitroglycerin is old and they go to take it, it may not work for them. When the EMS arrive, they will actually open a brand new bottle of nitroglycerin. That way they know it is fresh and should be working for that patient. Anything you'd like to add, Professor York?
Yeah, awesome, really, really awesome points about the discharge teaching and patient information. And just like with Professor Stocker saying, the patient, if they're using a medication that's out of date, it's obviously not going to be as effective. So try to remind yourself, what is the feeling or the sensation that our patients should feel when they take a nitroglycerin tablet? It should feel like it's fizzing in their mouth. It should feel tingly. And if it doesn't, it's not good anymore. It's also not only sensitive to light, but it's also sensitive to heat. So we have patients in the past that keep their nitroglycerin tablets like in their wallet, or maybe gentlemen that keep their nitroglycerin tablets like in their front shirt pocket. When it starts to get around body temperature, it can also degrade the medication. So they probably shouldn't be leaving it there either. So other really important things to think about, because especially when you're needing nitroglycerin, it's not a time where you're like, well, I hope it's working. You want to be abundantly sure that it's going to help you. And it is 3 months after after opening the container, the nitroglycerin is out of date at that point. Okay. Good question. Thank you.
Okay, so moving on to angina and MI procedures. If the patient is having significant angina, so this would be considered unstable angina, or maybe that patient is having an actual MI, they're going to need some form of treatment. When you're looking at the disease processes as you study, if there is a procedure that's recommended, ATI loves procedures. And what do you need to know for that patient to go? What do you need to do when that patient comes back? When we look at cardiac catheterization, we need to make sure that the patient understands the limb that's going to be used. So one of the newer approaches is a radial approach, or in emergency situation, they still love to use the femoral artery approach because it's such a large artery. It's easy to access. However, that also comes at increased risk. When that patient comes back, they're at a very high risk of bleeding from that site. Very important that we are doing our post-op vital signs on the patient, looking at the actual site and palpating around the site to make sure that there's no blood pooling or hematoma forming. And then checking distally. This is an artery, so blood will flow distal, and we need to make sure that that foot, the lower extremity, is still being well perfused. Checking the quality of pulses, the capillary refill, the color, and the temperature of the skin. And then depending if your patient had the groin access, that they understand that their head of the bed can be no higher than 30 degrees. They have to keep that extremity straight for that healthcare time frame. And that time frame will differ depending on how they sealed that artery closed. but it's typically somewhere between 4 to 8 hours of bed rest and keeping that extremity straight. If the patient starts to cough, we want them to hold pressure over that site because that pressure could dislodge the clot that's forming there. The patient will also need, because of the dye received, to have their kidneys well hydrated and flushed out. They're going to typically have fluids ordered after the procedure to do this. And if the patient is allowed to eat and drink, we also encourage them to drink water to flush their kidneys. If they're, the other thing I want to mention, the left heart cath is the same as a cardiac angiogram. I'm going to say that again. Left heart catheterization is the same as a cardiac angiogram. Cardiac angiogram means that we are injecting a dye into those arteries, coronary arteries, and we're looking for any blockages. After that part of the procedure is done and they see a blockage, if it's just typically one blockage, they will do a balloon angioplasty. That's the PTCA. We're going to take a catheter, and at the end of it is a little balloon that they will inflate so that the plaque will go against the vessel wall. And if it's a large enough artery, they will then deploy a stent, a thin metal sheath that will then hold that artery open.
Professor Stalker, I'm going to stop you just for a second. I'm not sure if it cut out just on my end, but it looked like your bandwidth cut down. So will you pop back to the beginning of that sentence just to make sure that it was on recording?
Okay, yes. If so with the cardiac cath, okay, so if they need to if they find the blockage, they're going to use the balloon. So this is the PTCA, percutaneous transluminal catheter angioplasty. They're going to use the balloon and they will blow it up, and that's going to displace that plaque against the vessel wall. And then they will deploy the stent to keep that artery open. When patients have a cardiac catheterization, PTCA, and a stent, it's very important that they understand medications that are needed on discharge, such as an aspirin. And then either they'll be taking clopidogrel, and I'm going to leave it at clopidogrel because the questions that I've seen through ATI still revolve around clopidogrel. These are two different antiplatelets that work at different levels of the platelet to make sure that the stent will not clot off. If your patient has multivessel disease, then the healthcare provider may be recommending surgery for that patient. We abbreviate this surgery by CABG, call it a CABG, coronary artery bypass grafting. And the purpose for this surgery is to revascularize the heart. They're going to take grafts and sew them from the patient's aorta and bypass that area of that plaque to reperfuse the heart. The questions that ATI focus around this are going to be priority assessment questions. What should the nurse be assessing on these patients after surgery? The main complications that we can see, one is going to be hypothermia. In order to do these surgeries, the patient's body temperature is cooled down. And when they come out of the surgery, we gradually will rewarm these patients using warm bath blankets, a convection air blanket. And we continually monitor their temperature. Bleeding is also a risk. This is a very vascular surgery. For the bleeding, we're monitoring their vital signs and their chest tubes for the drainage. They will have a shift in volume status. These patients will have a pulmonary artery catheter in place. We are trending their CVP readings to be looking at their volume status. If we see low central venous pressures, CVPs, that means that this patient needs more volume. And the last risk I have is bradycardia. In order to do this surgery, the heart is either stopped or the heart rate is extremely slowed down so that the surgeon is able to sew the grafts onto the myocardium. After surgery, these patients will be on a transvenous pacemaker, and that is through epicardial leads. Professor York, if you can put epicardial in the chat so they can see that. So bradycardia is treated with a transvenous pacemaker. When we look at discharge medications, very common medications that we can see are beta blockers, an ACE inhibitor, and statins. These would be medications that you should review going into the CMS. Anything you would like to add, Professor York?
No, I think that covered it.
Okay. Good, then we're gonna move on to dysrhythmias. First, we're just gonna start with basic ECG. With the CMS tests, as you probably saw with practice A and practice B, they can give you some rhythm strips. And they may also ask you to identify certain areas of the patient's heart rhythm. What I want to point out is the PR interval. And this is where the P wave starts and it goes to the very beginning of the QRS. It is this interval, the normal interval, and you can see it in the left corner, is 0.12 to 0.20. If we see that this interval has become longer than that, it is going to be called a first degree AV block. This means that there is a delay in the conduction from the SA node all the way down to the Purkinje fibers. This could be caused from medications. Some electrolyte imbalances can cause this. In some patients, this is normal. However, if this is a new finding on your patient, that would be a change in condition of your patient and we would require a healthcare provider notification. You may also be asked to interpret rhythms based on a picture. And I want to point out the subtle differences between atrial fibrillation versus atrial flutter. In the top rhythm strip, you see a picture of atrial fibrillation, and you can see this squiggly baseline. There is no defined P wave. The QT interval is intermittent through it because it's really distorted from the quivering atrium. You can still see that the R waves are coming through on this rhythm and that there's huge variability from R wave to R wave. The bottom rhythm strip is an example of atrial flutter. Here we can see the flutter waves going throughout the baseline. There is no defined PR interval. There is no defined QT interval. And typically, patients that are in atrial flutter are going to have a pretty normal pattern between or spacing between their R waves. And you can see the example of the arrows. I have the same arrow going from segment to segment on the rhythm strip. Our goal for these rhythms is always to restore them to a normal sinus rhythm if possible. If that is not possible, then we look at using medications to control the heart rate to try to keep the heart rate less than 100, and then medications to prevent clots forming in the atrium. Pacemakers. There are many different reasons why your patient may need a pacemaker. A very common reason is because their heart rate is too slow. It can also help control abnormal or fast heart rhythms. It can make sure that the ventricles are contracting normally, especially if your patient has heart failure. It can coordinate the electrical signals so that the patient has an even heart rate, adequate heart rate for cardiac output. How long does a pacemaker last? When a patient has a pacemaker, they will actually get what they call pacemaker interrogation, where either a pacemaker nurse, a nurse that's been trained in managing pacemakers, or a company representative will actually look at the programming of the patient's pacemaker, and they can actually see the battery life, or what they call the generator life, on the pacemaker. It really depends on how much the patient is needing to use the pacemaker. Is it pacing every beat? Is it pacing every third beat? The more they use it, the more battery it will take from the pacemaker generator. Typically, we can see pacemakers lasting 5 to 10 years in patients. Pacemakers are also coming different sizes these days. Here is an example of a pacemaker in the middle that is what we traditionally see, and that gets implanted underneath the patient's clavicular area. They have to do an incision, create a little pocket for it to sit in, and then there's wires that will come out and get threaded into the patient's right atrium and right ventricle. And the patient spends about 24 hours in the hospital to have this procedure done. The pacemaker that's next to it is a newer pacemaker, and this one actually will sit into the patient's right ventricle. It does not require any wires. It's all self-contained within that unit. When your patient does have a pacemaker, there's certain education that needs to be provided at discharge. We need to make sure that they know how to take their pulse so that they can take their pulse every day. And if it is lower than the set pacemaker pulse, they're notifying their healthcare provider. That they need to avoid high output electric generators. And this is even those when you are going to the shopping centers or Walmart where they have those anti-theft devices. It is okay to walk through those, but it's not okay to be standing next to it for long periods of time. They need to have their pacemaker card. They will be getting a pacemaker card from their pacemaker manufacturer. They need to be carrying that in their wallet. That's going to give the information, the settings of their pacemaker, the manufacturer of the pacemaker. It is safe to use microwave ovens with your pacemaker. The other issue that's coming out with pacemakers is batteries or magnets. Let me take that back. So magnets, when we look at MRIs, we're saying to avoid the MRIs because of the magnets could be too strong. Also, cell phones have magnets in them, especially the iPhone 12 has 3 magnets in there in that phone, and you should not be using your cell phone on the same side that the pacemaker is in. It should be the opposite side. Some of the newer pacemakers may be safe for an MRI, and that would be on that patient's identification card if their pacemaker is compatible with the MRI. So what additional information would we need to educate? They're going to need to know how to take care of their incision if they have an incision. They should not be getting their incision wet for about 3 to 4 days after surgery. We want to make sure that that skin has started to seal up. If they get an infection, it's just not the surgical site that's getting infected. It is the actual pacemaker generator that will become infected. And this has leads that goes into the patient's heart. They also need to know what kind of restrictions, and that's going to be their arm restriction, making sure that they're not moving their arm above their shoulder. And that restriction is for about 2 weeks.
Professor Stockton, I have a question actually from the chat, and I thought we might chat about it, just open. So the question is, since we report a lower pulse rate set than the actual set pacer amount, do you also report a higher heart rate above what the pacer would normally output? So practice versus NCLEX probably differs a little bit here. But you would, depending on how high that output obviously would be, you know, if the pacer is set to contain or to maintain a heart rate of 80 and it's 90, okay, we'll try to figure that out because the heart is still beating on its own. And that's the important thing to remember. You're not shocking the heart every single time to make sure that it still beats. So the heart still has a mind of its own. It still has that AV node that's going to be firing on its own. We're just kind of giving it a little extra push every once in a while. So having a lower heart rate underneath what the pacer should be set at is an indication that the pacer is not sensing. We call that not sensing. So it's not really identifying what is happening electrically with the heart. So there's something wrong there. Above is not so much of a concern. Below means that there's something physically wrong with either the wires, the battery pack, the pacer itself, or pathophysiologically with the patient. I know we never want to blame them right off the bat, but I'm going to. So that's more of a concern versus having a higher heart rate above what the pacer would normally tell me, because I kind of expect that in certain situations. But a lower pacemaker means something's wrong. I hope that makes sense. Anything to add, Professor Stocker?
Yes, and a lot of these newer pacemakers, these are computer chips that they can actually program over a telephone. And they can change the settings, and many of these patients will have what we call a variable heart rate, where they'll have a low setting and a high setting. So that was a very good question. So you could get a report that the pacemaker is set from 75 to 130. Then I would be concerned if my patient was over 130, then I would be concerned what's going on with my patient. And the low one will make more sense on the next slide. But if you can just circle the pacemaker spikes, because on my screen they're kind of dark, even though they're in red. When a patient is ventricularly paced, you're going to see a tiny little spike before the ventricle. And what we want to see when we see that spike, we want to see contraction of the ventricle. We want to see that QRS complex. That means that that ventrically pace, that pacer spike has captured the ventricle. And that's our conduction. That's what we're getting the patient's cardiac output, being able to squeeze the blood out of the ventricle. And then on the next slide, we have those other problems we see typically when the heart rate is, oh, these are more pacing slides. Yes, okay. So pacing slides. So again, we're looking at the top one where it says atrial pacing. If it's just atrial pacing, we're going to see a spike where we would typically see the start of that patient's P wave. Know that the atrium has very low depolarization, so we may not actually see a P wave being generated with the spike, but we should be seeing a QRS. And then we have another great example of ventricular pacing, and this one here you can see the spike a little bit better. And then the bottom one, we have it set where the patient is getting both atrial and ventricular pacing. And then we have our problem. So if your patient, if their pulse is lower than the set by the cardiologist, this is some of the things that we can see. We can see where there may be no pacer spikes. I also want to preference that ATI will call pacer spikes pacemaker artifact. If you see that terminology in a ATI question, this is what they're talking about, those little blips that are generated from the pacemaker, from the energy that the pacemaker is delivering. In the top strip, you see that we are missing those little blips, those pacer spikes or the pacemaker artifact. Because the patient is not getting that electricity to the heart, there is no conduction to that ventricle. There is no capture. On this top one, we actually call this failure to pace because the pacemaker is failing to generate the pacemaker spike or artifact. And the second example of having a lower pulse than set is the no capture of the ventricle. Here you have equally spaced out ventricular activity coming from the pacemaker. So you see the pacemaker artifact, but in the third beat, there is no QRS. We did not capture that patient's ventricle. On these patients, we're going to wonder, what is their cardiac output? What is their blood pressure? And then on the third strip, we see what's called failure to sense. And this patient, they do have a fast enough heart rate. This would be a great example of a patient, they may need it for heart failure. And what we're seeing is that the pacemaker, again, it's a computer. It has to be able to see the patient's underlying rhythm so it knows when it should be throwing these spikes. In this instance, it's not able to see or sense that rhythm. It knows it should be giving the patient this electricity, so it's just going to start throwing it wherever it thinks it should be. And the problem with this is it could land on the patient's T wave. What is the patient at risk for if it lands on the patient's T wave?
Nothing in the chat yet.
Nothing in the chat.
No.
The only thing I'm seeing in the chat is what you're putting in the chat.
That's well, that's about it.
Okay, so to answer that question is the R on T phenomenon. So R on T phenomenon is not good. If electricity hits that T wave, it could send the patient into a lethal dysrhythmia. We're going to move on over to the GI section and talk a little bit about peptic ulcer disease and what we could see some procedures in these patients. When we have a patient that has an ulcer, one of the orders or prescriptions that we could see is that the patient may need to have a nasal gastric tube inserted. It's very important that when we have these tubes in place, that we are monitoring the amount of fluid that is coming out and the color of the fluid. Note that if your patient has had a gastrectomy and has a nasal gastric tube inserted, it is going to be normal to be seeing blood on this patient post-op, but that blood should start to clear up when that patient has been out of surgery. Okay, so it's normal initially to see blood tinge, but then it should start to clear up and go to our bile color in 12 to 24 hours. When we have a patient that does have this upper GI bleed, some of our concerns with how much are they bleeding? How fast are they bleeding? And always look back at that patient's vital signs. If you start to see that their blood pressure is dropping, their heart rate is increasing, those are showing us signs of hypovolemic shock. And then what color is their stool? The color is very important. If we have a patient that is vomiting red, we know that that is a fresh bleed versus somebody who's vomiting blood that is dark and partially digested, which oftentimes we call coffee ground. When we look at stool, is it black coming out, means that it's been digested, or is it burgundy with a bunch of clots? When patients are vomiting in these situations, know that they can quickly start to present with shock depending on how much volume they're losing, and that could cause an airway problem. And they're high risk for aspiration. So these patients may need to be intubated. Note that if your patient has an airway problem and they're vomiting, we want to roll them onto their side so that they don't aspirate on the content. And then provide them or use a Yankauer suction so that we can clean out their oral airway. One of the procedures that we can also see is a gastric lavage. If your client, the first thing you need to do is assess your client to see if they have a gag reflex. If your patient has no gag reflex or it's diminished, this is a contraindicated procedure because the aspiration risk would be very high. We're going to insert a nasal gastric tube into the patient, and then we're going to use 0.9% normal saline. And we want this to be either room temperature or slightly warm. We're going to use the 60 milliliter syringe and lavage that. And we're going to instill the prescribed amount of volume from the healthcare provider. This is typically around 200 to 300 milliliters of fluid. After we've done the installation, we're going to reconnect the patient to the section that is ordered, or the healthcare provider may want this to flow out by gravity. We need to document the amount, color, and contents.
One thing I'll add with the gastric lavage, just as a quick kind of to help you take your mind to somewhere else, because as you can tell, you guys have already taken a few CMS at this point. So you already can kind of anticipate what good things are that might be a good idea to remember. So just like with what Professor Stocker said, remember what would make that procedure contraindicated. What a fabulous ATI question that probably is. Also think about what would we have to watch out for after we do a gastric lavage. Think about anytime that you have someone with an NG tube with copious amounts of output, think about fluid balance. Think about electrolyte imbalances that the patient might end up going into. That acid-base metabolic states. What would that look like? And how would I be able to identify it in a patient after a gastric lavage? So those are all little things that by this stage, you guys it's really important to make sure that you're honing in on all of that. It's not just talking about checkbox, I know what to do with a gastric lavage. I need to take you a step further than that. So make sure that you're always kind of hearkening back to that old information of what can I do? How do I identify other problems that are happening? Because you know that that's the stuff that they're going to hit you on.
Mm-hmm. And then when we look at, I just want to point out one more thing on that slide is, you know, if your patient is responsive, we follow ABCs. But if they're unresponsive, we're going to go to circulation, airway, breathing. Circulation becomes the #1 problem on these patients. And you can see that, you know, upper GI bleed is pretty much all encompassing. It could be from an ulcer. It can be from esophageal varices. It could be from a rip in their actual stomach or esophagus. There's many things that can cause a patient to have an upper GI bleed. And if they're losing volume quickly, they can become unresponsive. Okay. On this slide, I want you to look at the colostomy patient and look at the pathway of how you see the appendix. There's no real small bowel being shown on the slide, but you see the appendix and the start of the colon. That is going to be the patient's ascending. And then as we go across by the stomach area, we see the transverse. And then as we start to go down to the rectal area, we see the descending. Know that on a colostomy, the closer it is to the patient's small bowel, the more liquid that fluid is going to be. Where they're going to place the ostomy really is going to depend on where's the disease that they have to take out. And when we look at why the patient could have their colon, we can see ulcerative colitis, Crohn's disease, and then also cancers. You know, some signs and symptoms that your patient may have colon cancer, they can be fatigue, anorexic, change in bowel habits, alternative or alternating diarrhea to constipation. We can see distension, black tarry stools, increase in flatus. We might see the abdominal mass, but I've seen many patients that have had colon cancer and there was no mass until they went in. And also, recently, they just decreased the guidelines for routine colonoscopy screening down to the age of 45. When we have a patient, and then the other one is your ileostomy patient, know that your ileostomy needs very specific discharge teaching because they're missing so much of their GI system and their colon. The colon is really designed to help start to pull water back into their body. And here they're going to be losing so much water from having an ileostomy. In the first 2 months, we want them to avoid high fiber foods. We want to make sure that they're really chewing their food very well and increasing their fluid intake because of all the volume loss that they're going to have. When they start to add the high fiber foods gradually, we want them to watch out for signs and symptoms that would be identifying of a bowel blockage or obstruction. And then if they have an ileostomy or colostomy, know that this is going to be a body image change. If you think about wearing your poop on your belly, that is going to be very significant, both to the patient and the patient's significant other. Okay, so here we have the cartoon picture of a patient that has the later clinical manifestations of cirrhosis. Know when we see these patients early into their disease process, their assessment findings are very mild. When we look at jaundice initially, we have to be looking at their eyes to look at that jaundice. In the later stages, these patients are glowing like orange, pumpkin orange. They're going to have, in the early stages, they're going to have increased liver enzymes. Their AST, their ALT are going to be elevated. But as they progress through this disease, their liver is going to, all of those liver cells are going to scar and then go into fibrosis. And then eventually there are no more liver cells left to be injured, and their AST and ALT is going to go back to normal. So in the beginning, know that they have minor assessment changes, abnormal liver function test, but in the end stages, they have significant clinical manifestations. And because there is no functioning liver, their AST, ALT is normal, but everything the liver does is going to be abnormal. The liver is not going to be able to handle the ammonia levels anymore. And so we're going to see that this lab is going to start to increase on the patient. And to counterbalance this, the patient's going to get lactulose and rifampin. We're going to see that there is no synthesis of vitamin K. That is going to result in an increased PT, prothrombin time, and INR, international ratio. These patients in the later stages, all of their volume is in the tissue. They're very edematous and they have lower vascular volume. That's going to decrease that perfusion going to the kidneys, and that's going to result in an increase in their BUN and creatinine. As the patient is going through cirrhosis, some of the medications that the patient can take early on to try to lessen these later clinical symptoms is going to be propranolol. That is in the beta blocker family, and it's to decrease the pressure, that portal hypertension that's going to develop in these patients. Spirolactone is a diuretic that is going to help decrease the fluid volume that we see, their ascites that we see. Okay, any questions in the chat? Okay. Hepatitis. When we look at patients with hepatitis A, this is, viral hepatitis, and basically this comes from unclean sources. And patients can get hepatitis A, and it's very important to, make sure that we are educating staff that when we have these types of patients, how important hand hygiene is. And, really promoting good sanitation. Making sure that the patient is washing their hands after every bowel movement and prior to eating. These patients need a private room if they're actually incontinent of stool and or has bad personal hygiene. The treatment for hepatitis A is immune globulin for 1 to 2 weeks after their exposure. For healthcare, it's very important, again, we're washing our hands after any direct contact with the patient and that we're following our infection control procedures at the facilities. Pancreatitis, this can be a very painful disease process. Oftentimes in patients with severe acute pancreatitis, you will actually see them in the fetal position trying to relieve their pain and discomfort. This happens because there's been activation of pancreatic enzymes inside the pancreas instead of the intestinal tract. There has developed some edema, and the duct that is to direct the enzymes to be released into the duodenal area are inflamed, and the pancreatic enzymes can no longer get into the small bowel, and it just releases. Anything that would normally stimulate pancreatic enzymes is still going to cause that release. The pancreas does not lose its function. It continues to release. And then what's going to happen is that we have autodigestion of the pancreas itself. We will also start to see these enzymes then being taken up into our circulation. And we can measure this. We measure the amylase. We measure how high the lipase is. With patients, we can see that they're going to, again, have that abdominal tenderness and muscle guarding. It can radiate to their back, their left flank. It's worse if they lay down flat or straight. Patients have a very difficult time to eat because the abdominal pain gets worse. And we can actually start to see the seepage of blood to the abdomen as a result of the pancreatic enzymes breaking down that area. Fistulas can actually form in the peritoneal cavity. These patients become a very high risk for developing a paralytic ileus. They can develop hyperglycemia. And they can also develop ascites as inflammation is happening to that peritoneal. One of the direct responses to inflammation is the movement of water to that area. Some of the labs that we're monitoring for this patient is going to be their calcium. These patients can develop a very low calcium level. And then we're watching their white count. Typically, these patients are not infectious to start with, but they have a very high level of becoming infected. These pseudocysts that they're developing can become prime areas to have infection. As the patient starts to deteriorate and not want to move, they can also develop a secondary pneumonia. And this can also go directly into ARDS. Professor York, anything you would like to add?
Nope, you're doing great.
Okay. So when we look at management of this population, one is to really relieve pain on these patients. One of the best ways is to really give this patient a PCA so that they can control the pain medication they're receiving. Hydromorphone is the pain medication recommended, or fentanyl, not morphine, because morphine will actually make the sphincter of Oddi contract and can cause more pain in this population. We need to replace fluids because I said fluids are seeping from their vascular space into the peritoneal area. They are going to need fluid replacements, and one of the risks is going to be hypovolemia. And then nutritional support. The best nutritional support is to feed them with tube feedings into their jejunum. We want the patient NPO, so they will actually have a nasal gastric tube draining their stomach, but a feeding tube feeding their jejunum. Patients do the best if they can have actual enteral feedings. If they do not tolerate that, then we can do TPNs. No lipids, because of the fat would increase more pancreatic release. If they do have an infection, if their pseudocyst becomes infected, then the antibiotic of choice would be Primaxin. And these patients, it is going to take several weeks to several months for them to actually recover from this, and they can require psychological support in the recovery. Did you have anything to add, Professor Yard? Okay, so then we will go on to trauma. When we look at patients that are going, I should say shock, when we look at patients that are going into shock, know that they go through steps to get to refractory shock. It just doesn't all of a sudden happen. Depending on what's causing the shock can also determine how quickly the shock forms. In the early stages of shock, we call this the early signs, where we see a slight decrease in the patient's blood pressure, and there is starting to be oxygen problems at the vital organs, but the patient is able to compensate. This kicks in, the patient is able to compensate. And what we're seeing is that that RAS system is going to kick in, and we're going to see an increase of the antidiuretic hormone from the pituitary, so that the patient is going to start to hold on to water. This is going to also restart the release of the catecholamine. So we're going to see their heart rate start to go up. They're going to be a little restless. This patient, when you assess them, at first you're going to think that the patient is not with the program. They're just slightly off. But as you start to talk to them and start to ask the orientation questions, then they're very clear. When they can no longer compensate, this is when they're going to go into progressive shock. This is when we start to see the lungs fail and the kidneys fail. And these patients are going into multiple organ dysfunction syndrome. And we need at this level to start supporting all of those organs. This is where the patient is going to have the rapid sequence intubation and go on mechanical ventilation. This is where we're going to start seeing CRRT, continuous renal replacement, being used on the patient to support their kidneys. Volume to support their blood pressure, and vasopressors starting to be added and monitoring the patient for cardiac dysrhythmias. Every support we're giving, we're trying to reverse the stage of shock. If we can't reverse it, then the patient will go into refractory shock. Okay, so on to trauma. Okay, so trauma, when we look at patients that have been through a trauma, we're going to use the acronym A through I. This is looking at our primary and then our secondary survey for trauma. A great way of looking at the airway is using the acronym AVPU. This will quickly identify, is the patient alert? Do they respond to verbal? Are they only responding to painful stimuli? Or is this patient totally unresponsive? Airway is the #1 problem in a trauma patient, followed by #2, which is going to be breathing. When we're quickly assessing their breathing, know that we want to look at the depth of the respiration, the quality of that respiratory effort. Is it driving enough for this patient to support breathing, or does this patient again need to be intubated? Circulation, we're quickly looking at the color of their skin, cap refill, the quality of their pulse. D, we're looking at any neurodeficit. And this is where we're also getting that GCS score, which is very important. You have to know the GCS score or how to use the GCS in scoring your patient. When we look at E, where it says E for exam, this can also, this is the point I should say, where we are quickly cutting off the patient's clothes. You know, if your patient comes in with an abdominal wound or a chest wound, the only way to fully assess that wound is by removing their clothing. When it comes to F, this is where we're getting that full set of vital signs, getting that family to give us pertinent, quick information on that patient. And G is here they have get vital signs, but I also know it as getting our resuscitative adjuncts. So this would be getting our labs drawn and any definitive test that needs to be done immediately to be looking at the critical illness of this patient. This is done to help us set our priorities. It's very quick. In 1 to 2 minutes, this assessment is going to be completed by the trauma team. And in order to do the head-to-toe assessment, that full head-to-toe assessment and inspect their posterior surfaces, some of these trauma patients have to be cleared to be coming off the backboard. Some of these trauma patients may not even get to H and I. This is that secondary survey until they've been to the operating room to be stabilized.
I will hop in just to clarify here really quick. On this, obviously this table here on the right-hand side of the slide is your Glasgow Coma Scale. We obviously don't expect you guys to know like each number of a Glasgow coma, but I do want to point out to you that the verbal response section of this is for infants, not for adults. Because normally for best verbal response and a number 5, a score of 5 would be oriented to person, place, and time, not smiles, coos, and babbles. I would hope that adults would have better. If I had an adult patient who is smiling, cooing, and babbling, I would be freaking out. Okay, not good. So a score of 5 for an adult patient is oriented to person, place, and time. The second, a score of 4 for your verbal response is confused. So when you talk about confused, it's if you ask a patient, you know, what month is it? And they say December because it's snowing outside. Okay, like you answered the appropriate question, but you were just wrong in what you said. A score of 3 is what we call inappropriate words. So if I were to ask Professor Stocker, what month is it? And she says, I don't know, I had a turkey sandwich for lunch. She's still making words, she's still attempting to speak, but what she's saying to me makes absolutely no sense. So confused is I answered the question incorrectly, but I'm in the right ballpark. Inappropriate words is totally different topic. Number 2, or a score of 2 on our adult Glasgow Coma scale, is incomprehensible sounds. That would be more of a cooing and babbling in my brain. I'm neurotrauma specialty, so that's where I would go. Incomprehensible sounds, moaning, groaning, kind of a thing. And then a 1, obviously, for a verbal response would be nothing. So just make sure that we're not focusing totally on this. Glasgow, I was looking at that and said, that's not an adult thing. So just as a make sure, just kind of star that, maybe write your own notes, whatever the case may be. But please remember that that is not an adult Glasgow.
When we also look at trauma patients, know that they might need to have a halo brace on or different orthopedic apparatuses. So kind of review that information when we're looking at these types of patients. How would you take care of a patient in a halo brace? What education do you need to provide to a patient and or family member that have a halo brace? You know, how do they need to walk with crutches if they have a leg immobilizer in place, or if they have a cast or a non-weight bearing on an extremity? Okay. Hypertensive crisis. This is really important that we recognize when our patients are going into this, because this is really a medical emergency. There's many different reasons why we can see this happen, but one where it says medication non-compliance. This is typically that patient that has decided not to be taking their blood pressure medication anymore. Either they just don't think they need it, or they feel like they can't afford it. And it's very sad because these patients will go on to develop an intracerebral hemorrhage because their blood vessels in their brain can just not take this pressure. We want to make sure that, again, we're recognizing it, we're administering them antihypertensive medication. We're not giving them a diuretic. This is beyond just high blood pressure treatment. This is giving them the antihypertensive medications such as nitroprusside, nicardipine, or labetalol, and slowly bringing that blood pressure down. If we go too fast, we can cause cerebral edema. So we want to make sure that we are cautious by the percent we're bringing it down every hour. And these patients are really good candidates to have an arterial line in place. So we have that constant blood pressure medication and can really titrate these medications to that blood pressure. Otherwise, we're doing blood pressures, the cuffs inflating about every 5 to 15 minutes, and that can be pretty uncomfortable on the patient. And then assessing neurostatus because of that risk of bleeding into their brain. And because of the medication, we're using that continuous EEG or ECG monitoring. Okay, so Raynaud's phenomenon. This is a vasospastic disorder, and it can either be primary, meaning that this is the patient's problem, or it could be secondary, caused by other medications such as scleroderma. A systemic lupus is known to cause this. And the findings that we see, and I put some pictures so you could actually see the pictures, is it was going to cause that vasospasm. Typically the fingers, the toes, the ears, the nose are the places most affected. And that decreased perfusion is going to have that pallor. So in that first picture, you just see those white fingers because there's no perfusion happening. And then in the next picture, you're going to see that they become cyanotic. Once the cyanosis, once we start to get the stimulation or the blood flowing again, we can see that they can actually start to swell and become rubor because of the hyperemic response when the blood flow is returned. Patient is going to describe the sensation as being numb, an aching pain, tingling sensation. We want to make sure that these patients know their triggers. One of the triggers can be cold. We want them to avoid extreme temperatures. If they're smokers, we would ask them to stop smoking because nicotine is a potent vasoconstrictor. Also, caffeine, they were asked to avoid caffeine. And there are some over-the-counter medications that can cause vasoconstrictions, such as pseudoephedrine. Medications to treat this is going to be sustained release calcium channel blockers, such as nifedipine is the first-line drug. Peripheral vascular disease assessment. What I want you to do with this chart is look and compare the difference that the patient is going to have if it is an artery causing the problem versus a vein causing a problem. Their presentation is going to be opposite. So if you had a question and you were to recognize the differences between the two, know that if you don't have blood going distal, that cap refill is going to end up being prolonged. If you don't have blood going distal and they're walking and using that calf muscle and it doesn't have adequate blood perfusion, they're going to start to have pain when they're walking. Their skin temperature is often going to be cool, their skin texture thin, shiny, taut, and their toes, the tips of their toes are what's going to go first, and we're going to start to see ulcer formation on their toes. And eventually, if we cannot restore the perfusion, these are actually going to necrose and gangrene can set in. So these two, again, they have very different presentations. So study the different presentations that they have. When we look at the care for these patients is also going to be different. One of the treatments if the patient has peripheral artery disease is we want to reopen up the blood flow going distal. These patients are going to have a procedure. They can do angioplasty to the leg, just like they can do angioplasty to the coronary arteries. Priority action is we want to make sure that afterwards that patient is maintaining adequate circulation. What is the color of the extremity? What is the capillary refill? What is the quality of those pedal pulses? And then assess for the complications that are going to come with the procedure, and making sure that we're turning these patients versus if your patient has peripheral vascular disease, they have too much volume. They can't get the volume back to the heart. These patients are going to be wearing some sort of compression stocking. We want to make sure they understand that they need to avoid prolonged sitting or standing. We want them to be elevating their legs throughout the day. And these patients will often develop a wound around their ankle. They're going to need to understand the treatment and the wound care that's involved, and then how to help their skin stay moisturized by using daily moisturizer, and this will help decrease itching and prevent that skin from cracking. One of the things that you can also see in this population because of that itching is you will actually see scratch marks on their skin, and they will develop a secondary cellulitis infection because of that. Next slide. Both of these patients do have the potential for an amputation. But know that amputations have two pathways, either the way that we're talking, or maybe this patient was involved in a motor vehicle or a farming accident and needed to what we would call a traumatic amputation. Some of the goals of nursing care is really looking at the psychosocial needs of your patient and getting them to adapt to a body image change. Another nursing is going to be looking at the wound and that dressing, being able to record the characteristics of what that wound looks like, if there's any drainage on the dressing, how much is the drainage, what color is the drainage. And then preventing complications, such as infection, managing the patient's pain, which we'll get into more detailed here in just a few seconds. Palpating the distal end of that residual limb, we want to look to see if there's any warmth because this can indicate infection. And that infection could actually go to the bone and cause osteomyelitis. We want to make sure that we are positioning the affected extremity in the dependent position to promote blood flow and oxygenation to the tissue. So especially if your patient had an arterial problem, that would be very important. And when we look at pain, these patients are going to have several different types of pain, and it's very important that we are isolating what pain we are treating. For example, one of the pains that they can have is called phantom pain, where they actually feel pain in the extremity part that has been removed. And this pain can be helped. They're starting to give this population calcitonin during that first week because it has shown to decrease this type of pain. They can typically will describe this as a shooting, aching pain in that type of in the extremity that's been removed. By that description, they can put the patient also on propranolol that has been shown to help with this pain. And if they're describing more nerve pain, then the patient can be prescribed gabapentin or pregabalin. And then non-pharm is also helpful for this population, such as massage, biofeedback, acupuncture. Any questions in the chat?
I'm answering a couple, but otherwise, no, everybody's just diligently taking notes. It's also week 6, so we get it, trust me. It's a lot of information coming at you. And again, remember, this is all high level aspects. This is no new information. We're just trying to help you kind of dig it out a little bit. Some of you might have taken Med-Surg and Adult Health 1 and 2 maybe about a year ago. So we know this information is there. It just might be buried under PEDS and OB and mental health and all of that other kind of stuff. So we just have to kind of absolutely dig it out a little bit. So we totally understand it's a lot coming at you, only a little bit longer. So keep holding out. And I will just kind of piggyback off of what Professor Stocker was saying too. A lot of this is going to come down to the psychosocial aspects of how to help these patients. You're losing a part of you, whether that be traumatically or surgically. It does come down to how we therapeutically communicate with the patients. The other thing that ATI and boards also seem to really like to harp on is teaching patients aftercare. So we should not be allowing the patient to be using lotion on the stump because that's going to make the skin too soft. I know that doesn't seem like that could be a bad thing, but it is, because now we're not going to allow that skin to callus. If it doesn't get allowed to callus, then the patient will have incredible pain or not be appropriate for a prosthetic if that's what they decide to do in their own time. And the other thing that we don't want patients to use is any type of alcohol-based anything on their skin, because as we know, as healthcare people, alcohol is going to dry your skin out like crazy. And that's going to allow them to not only have just really poor skin, but it's also going to have an increase for them to potentially have infections. So I would definitely make sure that you're kind of starring those things to kind of think back to fundamentals as well of just basic care and comfort.
Mm-hmm. Okay, so our last topic is going to focus on renal and looking at hemodialysis. And when a patient is on chronic hemodialysis, they typically will get what we call an arterial venous fistula. And what they're going to do is put in a graft and redirect flow from and combine flow from the artery to the vein. Our assessment, we need to make sure that we are hearing a positive bruit and feeling a positive thrill. And this is because once they create this graft, we have arterial blood moving at a very high velocity through the vein. One of the complications that we can see from this is what they call Steele syndrome, S-T-E-A-L, Steele syndrome. And basically what's happening is the vein is stealing too much of the arterial blood flow, and not enough blood flow is going distally to that patient's hand and compromising that circulation going distally. You could see patient can complain of pain, they can have numbness and tingling in the fingers. When patients are on hemodialysis, know that they do have increased risk of developing hepatitis B, and they will actually get the immunization for hepatitis.
Also remember too that you can't immediately use a created fistula or a graft. We have to allow that process to what we call mature. Because just like Professor Stocker mentioned, when the patient goes on dialysis, the body is under such a high pressure system that if we didn't allow this created thing, a created access to mature, it would just rupture right away. So we have to allow the fistula or the graft, it's really a fistula, excuse me, to mature for about 3 months before we use it. So at that point in time, a patient will require different access while we let this process get better. And the size or the bore of needles they use in dialysis are 11s, 12s, and 14s. They're short, but they're pretty honking big. So think about, and every single time the patient goes for dialysis, they need to be stuck twice. One for the interior of the artery and the one for the side of the vein that brings the blood back from the machine. So one of the other complications that we can see besides hypotension and muscle cramping is the fact that we can create pseudoaneurysms. If we aren't prepared or we aren't taking care of that graft appropriately, when we remove the needles, the patient doesn't hold proper pressure, all of that can cause pseudoaneurysms and then ultimately render that graft or dialysis fistula completely useless. So we definitely don't want that to happen either.
Mm-hmm. Okay, so on to peritoneal dialysis. When you are taking care of a patient with peritoneal dialysis, look at the complications that can happen. Now, we have a catheter that's going right into the peritoneal cavity. Does the patient need to have a dressing? Yes or no? That's going to be up to that patient's healthcare providers. Some of these patients, once that stoma site has healed, may not have an actual dressing around the catheter, but know that whenever we access the catheter, we do have to clean off that catheter before we open it. And we always use a sterile process. Even in the patient's home environment, we teach them sterile, because this is a direct route into that peritoneal area and high risk of peritonitis. The solution that is used for this is a high glucose solution to create that osmotic gradient to pull the waste products and that water from the patient. When they first get their peritoneal dialysis catheter, because there could be a little bit of trauma, we could see that the first few exchanges do have some pink tinge to them because of the blood, but after that, it should really be clear. Being able to recognize signs and symptoms of peritonitis. The patient could complain of abdominal pain, rebound tenderness, cloudy peritoneal effluent, so the drainage coming out of the peritoneum. GI symptoms that they could have: diarrhea, nausea, vomiting, hyperactive bowel sounds. They may be running a fever. One of the ways to know if that effluent is cloudy is to put it against some print. So newspaper print or anything, maybe there's a magazine in the room, just any print to see if you can read through it. These patients also have a high loss of protein in these exchanges. They need to go on a high protein diet. And this could be a change in diet for this population as they were going through chronic renal disease and proteins were being restricted. Now they're going to be asked to increase their proteins. And then the administration. When we do peritoneal dialysis, remember that there's 3 phases. The indwelling phase, which is going to take maybe about 20 minutes to get about 2 liters of fluid into the peritoneal. And then that's going to sit there for several hours. That will be determined by their healthcare provider during the day, or maybe this patient's using a cyclic machine during the night doing all of these exchanges. But if they're doing them themselves and not using the cyclic machine, when they go to take the effluent or the drainage out, it's important they understand that they may have to be shifting their position side to side, or maybe just slightly palpating their abdomen to make sure they get all of the drainage out. And then once they have the effluent out, they're going to refill back with the indwell phase.
Think about the type of patient that would probably be contraindicated for this also. Just like Professor Stocker said, you're going to be indwelling maybe 3 to 4 liters at a time, upwards of 5 liters that are going to stay into the patient's abdomen. That's a lot of fluid. So think about patients who might have issues with their respiratory system. They have COPD, some chronic respiratory concerns. Their lungs now, with overtaking 3 to 5 liters of fluid in their abdomen, everything's going to be displaced upward. That diaphragm's going to come up. They're not going to have the ability to let their lungs expand as much as they need to. So someone who has some sort of a chronic respiratory illness is probably not an okay candidate for peritoneal dialysis. Also, what we've already mentioned is that we do require these patients to use sterile procedure at home. There's also people that might not be appropriate candidates for that because of their lack of resources, lack of access to resources, or their willingness to follow instructions. So a lot of other components that we have to look to, not only just looking at the other types of complications that we have. Sorry to jump in on you.
No, you're good. Okay, so on to transurethral resection of the prostate. when you look at a patient that requires the surgery, know that their number one complication is going to be clotting off their bladder. This is a very, to term the procedure, very bloody. And that's why they need that constant bladder irrigation, because when blood is together, it wants to clot. And we are going to actually control the amount of continuous bladder irrigation solution by the color of their urine. And the healthcare provider will tell us what color they want that patient's urine. You may hear the description that they're in report, if you've had this patient in clinical, that their urine is cherry color, or maybe a light cherry color. That cherry represents the blood, and we'll try to be slowing down this infusion. But if that patient starts to get a clot, they might start complaining of having bladder spasms and start retaining some of the volume. It's important that we are taping or having some sort of traction to the patient's abdomen or thigh, because we don't want to increase the manipulation of this three-way Foley catheter. So when you look at this disease process, look at what are the complications, and ATI is probably going to ask you, what is the nurse's priority action, or what should the nurse be the most concerned with following this type of surgery. Anything you would like to add, Professor York?
No, I don't think so. Again, I put it in the chat as well. You should always be able to see through the urine, whatever color it may or may not be. We really should be able to see through it, unless it starts to get really kind of clotty. It almost looks like the consistency of ketchup or like barbecue sauce. I'm sorry to do that to you. That's when we've got a real problem. We have to kind of identify what the issue is. And yes, so someone mentioned about avoiding the decongestants. You're absolutely right. It has to do with vasoconstriction. So definitely not something that I want after this type of a procedure. We also know it can mess with your blood pressure and things like that. So we don't want any of that to start to occur. And which is also why we want them to have laxatives and stool softeners. We don't want them to be straining afterwards. Because this is a relatively bloody procedure. You're burning through very friable or very fragile tissue in the bladder. So we just want to make sure that we're getting as much out and not allowing any complications to the best of our ability.
Okay, are there any questions?
Not seeing anything just yet. So this, guys, is a QR code that you can use to have attendance. So you get credit for being here today, as well as just a little survey afterwards. We understand that this is a ton of information, but we appreciate your time and attention here today. Very brief overview, things, essentially we're using this time today as things that you really need to hone in on. Wink, wink. So I know it's a lot, I know it is, but we have the utmost faith in you. Please continue to study, study, study hard. I know it's week 6, and week 6 is rough for every single one of us. So we understand the struggle that you guys are going through. We're almost there, almost a summer break. Keep pushing. You guys are going to do great. Reach out to your course instructors if you have any questions or comments. Otherwise, we appreciate your time today, guys. This is recorded again, if you'd like to revisit. Otherwise, we hope you have a great rest of your week. Thanks for being here.